Hi there, good afternoon. Just a small slide here just to see so you can put a face to a name of some of the people we've got supporting this, the first webinar for the Long Length of Stay Virtual Network. So as you can see, there's myself, Callum MacGregor, Kate Pound, Stefan and Angela on the chat room. So we consider that this will be quite successful if by the end of it you're able to understand the benefits of reducing long length of stay of hospital admissions for all the patients, their families and staff. If you can gain a better understanding of your role in leading and supporting this, and that actually probably the biggest one for us would be to see that you are able to make connections, ask questions and do some peer learning. So as I say, this is myself and Callum. We will be leading the session this afternoon. And my name is Kailyn Bennett, as you can see, and I'm a Senior Improvement Manager with the Emergency Care Improvement Support Team. And my professional background is a nurse within the NHS for the last 15, 16 years, and specialising predominantly within the emergency and urgent care setting, but acute medicine and acute cardiology. And for the last 2.5 years, I've been working predominantly across the London region, supporting the long length of stay ambition and supporting intensively some of the organisations across the capital.
My name's Callum MacGregor, so I'm an improvement facilitator with the Emergency Care Improvement Support Team. I'm a physiotherapist by background, so I'm one of the therapists that go around the country. Predominantly we do the long length of stay reviews. And within that, we do some therapy reviews, both on the wards and at the front door. We do some frailty, and more recently, we've been doing some risk and choice workshops up and around the country.
So what is it? What are we trying to do? What are we starting with? This is the first session of a 12-week new programme, virtual support, which we're inviting everybody to attend. So not just acute systems, across the STP and across communities, just to really understand and to try and provide some practical advice, and also to try and encourage you all to connect together and to build your own networks and in a safe place where you can ask questions of each other and start that peer-to-peer learning. So we know as we move up and down the country that actually some of the best conversations with the best outcomes are just those that we would normally refer to in my old profession as corridor conversations, where you get a real richness from having a chat, sparking ideas from each other and just understanding what's working well for each other. So we really do encourage that you use this opportunity to share your learning, share your ideas, and we want to help facilitate networks between you all. And in order to do that, we would like to ask you all to enter in, if you're willing, enter in your work email addresses so that we can keep a note of those and encourage these connections to continue throughout the programme. So our why as the Emergency Care Improvement Support Team. So we really do know that it's really difficult out there at the moment. We appreciate that winter has merged into summer, and actually the pressures out there are incredibly real and very difficult for all of you. We also know that actually you guys at the front of everything are probably the ones that have the biggest influence to make some of the changes and really make a difference to patients within your care. So we have the pleasure as ECIST of working alongside a lot of organisations over the years across up and down the country. So really warmly welcoming you all today. Just to, those of you that don't know what we do, what we actually offer is practical on-site support to staff that want to engage in improvement projects. And whether they're big or small, like I've just said, actually some of the best ideas come from a really short idea exchange conversation that is done informally and makes such a big difference. So we really encourage that we have those conversations today. So we also recognise actually the practicalities of releasing staff, especially at this time of year, to attend a workshop and a conference is really difficult. And actually, with all the goodwill in the world, sometimes short notice things happen and people want to attend but can't. So we're trying this way just to see whether or not we can connect with a wider range of people that isn't as time intensive as perhaps going to a conference or a workshop is. So we have a desire to continue to provide support up and down the country and to provide organisations with improvement support.
So what I'd like you all to do is quickly just write down the first thing you see with the screen in front of you. If you can just go into the chat room and write down one word, a couple of words, and we'll have Angela and Stefan kind of looking at responses. What we want to do is just get you to start kind of connecting with us through the virtual network to be able to use the chat room so that we know that you're with us there, and let's see what the responses are. So if I can go over to Angela to see what kind of responses we're getting in the chat room.
Hi. So, yeah, thank you to everyone who's responded. We've had predominantly, and I would say about 98% of people have said frog or toad. We've had a couple of people who have said horse, and some people haven't been able to identify, one or two, but, a lot of responses, about 97, 98% say frog.
So this is the exact same information, just presented in a different way. So yes, if you just turn or flip your head round to the side, you will be able to see the horse now. So when we relate this to long length of stay, because you're inundated and you're immersed in a very busy day-to-day clinical life, when you're doing the long length of stay reviews, you might just see one version of what's in front of you. And what we have the opportunity to do when we come to do the long length of stay reviews with you is kind of maybe look at it from a different angle, be able to try and be a bit of a critical friend. So I know you've been doing this for a long time, doing these reviews week in, week out, but we really need to try and improve the quality of care for patients and try and ensure that we're not keeping patients in longer than necessary. So it's just looking at what you're doing currently and seeing if you can look at it a slightly different way, whether that's from support from some of your peers or from ourselves. That'd be great. We have published the guide to reducing long-length hospital stays back in June 2018. And that goes through everything from, on page 29, there's a long-length stay reviews and what we would recommend for people to do. Say for patient flow bundle, there's the red to green, there's therapy at the front door. And just now, myself and the staff within ECIST, we're currently refreshing that so that we can try and get a new version of this or a more updated version of this out at some point this year. So we'll keep you posted as to what kind of progress we have there.
Okay, so what I just want to have a little question about with you all and encourage you again to give some responses via the chat room. We get asked this quite a lot as we're supporting organisations. So in the methodology that we would recommend trialling, we do recommend a roving review approach to the long length of stay reviews. But we also get asked and challenged as to what the difference is. So I guess we can tell you what we see, and I'll obviously go through that in a moment, but it'd be really helpful now just to take a couple of minutes just to go on the chat room and tell us what you think the differences are, whether they're benefits or not so beneficial. Just tell us what you think and what's working for you. So I'm just going to give a minute or so, and then Angela and Stefan, perhaps if you can round up some of the themes that come from the chat room in a minute, that'd be great. So what we know works well, this is our opinion, this is our thoughts, as we say, we have the privilege of working up and down the country. So this is what we consider works well. And it's a consistent approach with consistency of staff attending, including senior executives. Now, again, we appreciate that this is really quite difficult and quite challenging in time-pressured and organisations at times, so we are absolutely aware of that. The benefit of having executives or senior leaders on these rounds is really to bridge the gap between the reality for staff on the wards and what's going on for patients, and what they can do in some of the decision making at executive level can help influence some of the constraints. So we know, and we're told from staff also, that a timetable is really helpful. So staff knowing roughly when the roving team's going to be coming round is really helpful, just so that they know when they need to be around. It's something that's quite beneficial. One thing that I think we all would agree with is ward staff knowing their patients and aware of what their next steps are. And this can be really quite timely if people don't know what their patients are waiting for. And sometimes we hear that roving reviews, as we've just heard, can be really timely for people, and we appreciate that. Sometimes when you haven't got the most up-to-date information for the patient, then this will add time to the actual reviews themselves. Concentrating on patients with a length of stay of 21 days or more, we do recognise that there's a need to understand and work with patients up to a length of stay of 7 days, 14 days. We often have organisations that look at 10 days and 11 days, but ultimately, if we don't understand and look at the constraints for patients with a length of stay of 21 days or more, then we're not going to move people through at all, and people just get stuck. So allocated feedback and a commitment to do something about the top 3 constraints. So actually what we know is what is not helpful is if you have a roving review that take away actions and isn't fed back towards staff. And this can actually not help with duplication of messages, and actually it can actually delay things. So the thoughts and our advice would be very much, if you take an action away, that you really do make sure you close that feedback loop. And that as an organisation, there is a commitment to doing something about the top 3 constraints. So we know that knowledgeable and empowered staff and their understanding of the harm that can be caused to patients through deconditioning patients with an extended length of stay will always help patients move through their journey in hospitals in a much more seamless way. Okay, so 4 questions. I'm not going to talk through these, but what I'm actually going to do is just give you some thoughts and just pose a question, really. So again, for discussion on the chat room, maybe not now, but we can pick this up in the question sort of and discussion session after. But these 4 questions aren't new. They're very much about empowering patients, relatives and carers to ask questions and really try and manage their own care. So actually, it's not unreasonable for patients to be asking, what's wrong with me and what actually am I having done today? What's going to happen to me now? What we tend to find, and I think we would all have previous experience of a loved one, relative, or just observationally, actually, that sometimes this is really difficult to do. So I don't know if anyone's connecting on Twitter recently. Certainly at the weekend, there's been lots of discussion about patients, relatives being branded as difficult because they ask questions. So I guess the question I'd like to pose really is what causes us to feel uncomfortable giving the right amount of information and up-to-date information to our patients? So that's just something to think about, really. I know from personal experience, just to share with you, I had a personal experience recently where I actually could only get to number 2 of my questions of 4 because I was asked to stop asking questions and hassling people. So, you know, as I've said earlier, I've been in the NHS for a long time now, and actually I feel like I'm quite capable at navigating my way through quite a complex system at times, but actually, even with all of my information, I found it very difficult to get past question 2. So if that's how we feel as professionals, then really have to ask what that feels like for our patients. So really taking away from this bit is really start empowering our patients, relatives and carers to have those conversations and start feeling comfortable asking questions.
So just to kind of focus back on the patients again, there's some research that was done in Scotland back in 2014 where they looked at over 10,000 patients on a specific day, and they found out that when they followed them up at 1 year later, almost half of those who were aged 85 or over had already died. So obviously lots of people have seen the Last 1,000 Days campaign that's been on Twitter and on the internet. And I know from my own personal experience with family and friends that when someone's in hospital, we really need to try and get them home. We need to get them home as quickly as possible. The harm that we do when patients are in hospital, they're left to decondition, is really significant. And when you compare those who were 85, so half the people dying, with those who were under 60, they had a times 3 increased mortality than those of the younger cohort. This was a study done back in 2017 from Newton Europe, and they've also done one in 2019. But just some of the figures that were quite stark from this 2017 study, Why Not Home, Why Not Today? So almost 40% of patients who were delayed could have benefited from a different pathway decision. So a lot of the time when we go on the long length stay reviews, maybe at day 5 it's been decided that someone might go down a pathway 2, but then after 21, 25 days, we're still trying to get that patient down a bed-based rehab unit. And a lot of the time when you ask the questions or start digging a bit deeper, the patient might be transferring, mobilising with one. So that question is, why not home? Why have we decided pathway 2? Why are we not changing that decision? The second figure, 36%. So 36% of delayed patients were found to be waiting for a decision to be made on their discharge pathway. So from my own experience working at the front door and also on inpatient wards as a physio, we really want to try and encourage an expected date of discharge to be made very quickly within an admission and have a set pathway that we think, especially home first. The bottom figure, 60%. So that's 60% of assessments and or therapy could have taken place out of the hospital. So from my own point of view, from therapies and doing lots of talks around the country with therapists, both occupational therapists, speech and language and physiotherapists, a lot of people are doing stairs assessments, kitchen assessments, etc., that we should really try and focus, try and get people home with discharge to assess, with enablement, to perform those assessments in their own environment where they're probably going to do a lot better. And they don't need to stay in hospital to be doing those types of assessments. So both long-stay reviews that we're talking about today and also the Safer Patient Flow Bundle and Red to Green, when they're all deployed together, we see really positive effects. So when people are doing board rounds for patients that might not even be 21 days yet on a daily basis, when you're looking at Red to Green and making it value-adding every day for a patient instead of sitting around waiting for an investigation or a therapy assessment, etc., when you do all these things together, we really see really good results. So I'm just going to leave this bit of data up here. So there's obviously a significant amount of people who are staying 21 days or more across England. We want to focus this, although we have this national ambition, what we really want to do and what we appreciate as clinicians ourselves is that it's about the person in front of you. It's about making sure that the person is not staying in, because there's not many people who need to be in hospital for 3 weeks or more. And when you do start getting people in for 3 weeks, 4 weeks, 5 weeks, they end up becoming stuck. And we know most of those delays are internal to the acute trust. So we need to start looking at ourselves and thinking, what's the best we can do for our patients? What are the top 3 reasons for why patients are staying in our trust? And then try to do something about it. There's no point collecting the data and then just ignoring it, because then nothing will change and nothing will get better for the patients in your care. We have access here at ECIST to the long stays dashboard, and I would imagine with your business intelligence in your own trust, you should be able to have access to your own data. If you look, it's split up into those who are 21 day plus, 50 plus and 100 day plus, and this is for the whole of England. But what it does give you is a Pareto chart of the top reasons, and we would always say from ECIST that you would want to challenge yourselves at the top 3 reasons. And I don't know if you can see on the screen for those 21 day plus, the majority of patients, so 26.6% across England, are receiving ongoing treatment with a NEWS of 4 or less. And I know from our clinical background that those people with a NEWS of 1, 2, 3, we can serve those people at home. We can get community services in to look after those patients. They shouldn't be, after 21 days, still in a hospital bed, taking up acute medical care, nursing care, therapy care. So we need to spread the risk, get people home, and especially those that don't need that kind of acute medical care in an acute hospital bed. So with my current role with ECIST over the past year and doing the risk and choice workshops that hopefully some of you have seen or heard about, we always want to ask the question, well, what does the patient in front of you want? Because lots of them will say home, and then we as an MDT manage to try and change that decision because we think it's not safe enough or too risky. But if they came to their own bed, in their own home, then that's where we should really try to get them. Okay, the home first principle is pertinent across the whole country nowadays. And in addition, just the third point, when we go to the front door and people we see using outcome measures, so they're doing early identification of any frail patients, so those patients on the rock routes, for example, that are scoring between 4 and 7, you'd want to identify those patients, because once they get through your ED and your AMU and they get admitted onto wards, those are the patients that are really at high risk of deteriorating, deconditioning, the harm to infection, and could lose the ability to be able to get home and will never see their home again. And that's not what we want for anyone. This is just a quick slide that I stole off Christopher Tuckett, who's a physiotherapist by background, and it's what I use in my risk and choice workshop. It's because when people talk about getting patients home, it's not safe. Well, being in hospital is not safe, because I know for a fact when I was a physio with 52 patients on my stroke unit, we couldn't see every patient every day. So people do decondition, people do come to harm, they do fall over, they do get infections. So we need to try and really get to the point where we're making risk assessments, but we're getting people home. And we can't reduce risk to 0, and we can't make sure everything's 100% safe. So it's just about trying to change the terminology we're using and trying to focus on what's best for the patient. What do they want?
Okay, thank you, Callum. So to summarise then, and just to give you a little bit of heads up, we would like to have the next lot of discussions with you guys. So please get some questions ready for us and ready for each other, and some explanations about what's going on for you out in the systems. So to summarise then, we know, and you will all know, that harm is caused through deconditioning and a decrease in daily activity. We know that there is a decrease, natural decrease in activity for patients staying in hospital. And actually it's not just, although we talk very much about the frail patients, actually it's quite scary to notice what deconditioning can happen to patients in their 40s and 50s just by a decrease in their activity. So again, really very much about empowering each other and our colleagues out in systems to feel comfortable asking questions and to feel comfortable being asked questions. So we really should be comfortable asking our patients and relatives and carers to question us about what it is that we're doing for our patients today and what's holding things up today. So we know that we're the advocates for our patients. You're all advocates for our patients. Sometimes the patient's voice isn't able to be, that they, you know, the environments that hospitals are, as natural as they are for us, are really unnatural for patients. And some people don't feel able and confident enough to ask some of the questions. So we're there to do that for them. And as Callum talked about, we know that your own bed there's nothing like your own bed, and we need to prioritise this as the first option, whether that be your own bed in home or your own bed in a residential home. You know, let's not get to a point where we have to change from residential to nursing because patients have deconditioned in hospital whilst they've been in with us. So let's continue to share your contact details, and we're going to just go to the chat rooms now to start offering opportunities to have further discussions and further opportunities for questions for myself and Callum, but also for the rest. We've got a number of the ECIST team with us. But this isn't really about us as ECIST. This is about giving you the network and you the platform to just talk about what you've got going on and how things are for you and your reality and what other organisations are doing and how that you might take some ideas from each other to try in your organisations.
Thanks, Helen. Yeah, so while you were talking, we've had some questions come in already, or more discussions actually. So we've had some really good discussions around reviewing just the 21 days and over, or reviewing days 17, 18 to prevent them from slipping into 21 days and over. So we've had some really good discussions around that. What we would say is try where you can to focus just on the 21 to really get some traction. And Diane, one of our ECIST colleagues, made a very good point. Speak to the therapists on the ward. Talk to the therapists, ask for their advice and engagement to see if they can identify anybody, rather than reviewing carte blanche everybody who's at day 17 to 21, if they can identify anyone who they think may tip over. So that's a really good tip.
And also, what I'd say, Helen, is not to get too caught up in the exact number of days, because if we're applying the process in a rigid way, and we're using our top 3 constraints and resolving those 3 constraints, that's actually going to affect all patients potentially, no matter what their length of stay. So we don't need to get too caught up as to whether it's 17, 18, 20, 21 days. It's just a word of caution.
I think that works really well. I think some organisations absolutely want to look at different numbers of days. I think just you know, to note, we do know that if you are able to get this bit right with regards to your longer stay patients, then actually a lot of people find this a time limiting factor with regards to how this is done. But if you get the 21 days right, and actually that process starts becoming really business as usual and it's very robust, you've got all the bits in that slide that we've talked about with regards to doing something with your data, knowing your information, then actually, yeah, absolutely start looking at ones underneath that. But I think we really, you know, it's good to make sure that you've got your processes in place and that they're actually and that they're working for you.
I think that's a really key point, Helen, that, you know, do quality rather than quantity. And you're right, people get hung up about the numbers. You know, having worked with a trust who were reviewing 11+ days, it was taking 10, 11 hours a day to review those patients, and they weren't giving what we would recommend 2 to 3 minutes per patient on a review to be able to really get the traction with those really complex, longer length of stay patients. But by bringing it back to just reviewing the 21 days and over, they were able to spend more detailed time, I suppose. I've worked with organisations before who have managed to get sufficient traction over 21 days to have reduced it back, and they were reviewing 3 days and over. So as the numbers started to reduce to 21 days, they then automatically started to be able to bring it back further. And like I said, they were reviewing at 3 days. So it is possible, but it's just getting that initial traction there in the first place.
Absolutely.
So some of the other things that came out were who takes the actions from the reviews. We have the DPTL spreadsheet, obviously, that's filled in. What we always say, and as Stefan and I have been round any together, is that the actions can only be given to people who are in the room. Not necessarily those people are to deliver those actions, so it may be to wait for a doctor to review. If the doctor's not in the room, absolutely, you can't give them. They're still responsible, but the action sits with somebody who's physically in the room that they're then responsible for.
And the other thing I would say about the actions is what some organisations are doing now is, in terms of when they're going around and doing the reviews, they're building in some time for those team members to undertake the actions rather than waiting until the end of the process, which inherently creates a delay.
And the administrators, sorry, Helen, the administrator's really key in making sure that people know their actions. So a really good practice from the administrator would be to say, before you move on to the next patient, right, can I just stop? Can I clarify everybody in the room knows what they're doing? But it's also by giving a time as well, so not just giving an open-ended action of going and chasing or going and doing, but it's, I need you to do this action and I need you to do it by 2 o'clock or 4 o'clock and come back and give a point of contact so that they know it's done, that loop is being closed.
Yeah, I absolutely agree. You know, that feedback loop is, otherwise what happens is people, the ward staff, become seeing it as a tick box exercise rather than something that's really valuable and adds value to patients' care and patients' time. So it's really important that any actions that are taken away are fed back. And it's very structured. And in a similar way to the way we would, I know one of our sessions coming up in the next couple of weeks is with regards to board rounds. But one of the things is that it's similar with regards to how we would advise that actions coming from board rounds are dedicated to specific people. And just as a little note, we know that actually if you put a name or you call somebody by their name and you attach that name and person to an action, then it's more likely to get done rather than just leaving it, in the wind waiting for someone to pick it up, because there's an assumption that someone will and actually no one does. So that's another sort of top tip, and just a highlighting. It's the same with the long length stay actions coming. Is any other themes, Angela and Stefan, that anybody wants to talk about?
Mentioning the 4 questions, that triggered quite a bit of response in the different ways that the 4 questions can be not advertised, for want of a better word, to encourage patients, to encourage their family and their carers to be able to ask and put that challenge in, to be able to say it's absolutely fine to ask me as a staff nurse or as one of your is looking after you to ask those questions. I would expect anybody on any ward. What I say to staff when I go around is, just out of interest, do an audit, audit your patients, go around and ask them, just out of interest, see how many of your patients would know the answer to those 4 questions. It's very easy when you think that people know, but actually sometimes people presume, and presumption is where people fail. You should never presume that people know. You should say to people, ask me those questions. And there's nothing wrong with challenge. Challenge is fine as long as it's done, appropriately. But we should be challenging each other to make sure that our patients know the answers. So people were talking about having information on placemats, having it at dinner tables, having it on posters behind beds, having it as part of the admission paperwork so that it's automatically given. So there was lots of discussions around different ways that information can be got out there and made readily available.
And so that's really, really powerful, and thank you all for sharing those. I suppose my next question back to everybody is how are people finding, so the placemats, we've seen some really great examples of advertising of these. I guess are people comfortable having those conversations with their patients? It doesn't need to be any one group, but is that part of the working day now, that actually it's become, are we in a position where everybody is comfortable to ask their patients that they, and reassure that they know what's happening, and that there's not 5 versions of one care plan, as it were, as we see? So has anyone got any thoughts on that?
I mean, nothing's come through at the moment on that. I don't know if anyone on the chat room has any thoughts that they can send through.
If you think I mean, obviously I don't feel that old, but actually when I say I've been nursing for 15, 17 years, it makes me sound a bit old. But in the old days, as it were, you used to do your ward rounds as a nurse, and that actually some of that information sharing did seem to, at the time, it did feel as though it was a back and forth from the medical team to the patient. But actually, in hindsight, looking back, actually what that does is that if patients don't feel comfortable asking questions, then it allows people to just go back and reiterate exactly what the doctors are saying and what the plans are, or what to be expecting of. And unfortunately, nationally, we know that there's such huge workforce problems, and I know that the Chief Nursing Officer team for England are really working hard with the workforce and recruitment programmes. But actually the reality is that it's not common consistently to have nursing staff on ward rounds. And I think that was an opportunity to have those really robust conversations on behalf of patients and to aid patients to do that for themselves.
Yeah, I think that's absolutely right, Helen. And I think one of the key things as well is to set the expectations right from the start. So we talk a lot about patients waiting, but I think some of it is having those conversations, and some of those conversations can be quite difficult. And as long as they're said from a place of, the best interest of the patient, but have those conversations really early on with the family members where I'm a nurse by background, when you have a patient who you think, gosh, this discharge is going to be quite difficult, or there are going to be obstacles. Set those expectations. We have a choice policy, which is a document. A lot of organisations will rewrite the choice policy. We have links to which we can share the national policy, which has gone through all the legal loopholes and obligations that is sound, that trusts can just use for themselves, and really get that out there and use the letters so that patients and their carers know what our expectations are of them and what they can also expect from us.
Thank you, Angela. Can we just go back and see if anybody on anyone that's joining us would like to speak directly or to pose anything or connect with each other? Obviously, we wanted to use this opportunity for you all to connect together, and appreciating that sometimes that feels a bit uncomfortable, so no pressure by any means, but we do recognise this is a good opportunity for. So, for example, we often get asked where sites are doing something really well, and we would say, in our experience, all organisations we go to have really fantastic staff working there, and there's pockets of really, really good initiatives and ideas, and it might be that not everyone is doing everything, but there will always be good practice in the organisations that we will support, and that's really worthwhile sharing. So this is what we wanted to do with this virtual network, was to share and give you guys opportunity to share what you're doing and what's worked for you or what you want to try. So I don't know whether or not anyone feels brave enough to have a conversation, or if you want to put something in the chat room. And also, just to remind you, I can't see the chat room, by the way. That's why I'm not really, I know that Angela and Stefan are monitoring it. So just so I'm not aware of the conversations at the moment. But just to remind you all too, if you want to connect with people, we're really happy to do that and use your NHS work emails in order to connect people up going forward from this programme.
I think just to reiterate, we all know that there's lots of data out there within NHS, and when you're doing this weekly review and collecting this weekly data, if you're having the same conversations about the same patients week in, week out, or different patients with the same issues, if you're not going to do anything about sorting out the top 3 issues, whether that's to do with enablement of home, housing, care packages, whatever that is, so the majority of the things that we see are 70% internal, so it's something to do with maybe a therapy assessment, it's to do with waiting for investigations or scans. It's all majority of things, so 70% of those things are within the control of your trust. You don't have to look elsewhere, you don't have to look at social care, you don't have to look at any kind of community services to kind of fix those issues those things need to be fixed within your own organisation, and you have the power to do that. And if you haven't got the executive team involved in those kind of reviews, you're going to really struggle to make any change. So there's something around getting people responsible and getting people that can actually unpick some of these kind of delays for some of the patients, because once you're there for 3 weeks, the chances of you deteriorating and deconditioning are significantly high. So is everyone's...
That will help. We've got a question in the chat room, Kailyn, about a toolkit for deconditioning. If there's anybody, or if there's anything that can be shared, or if anybody's got any examples of what they may or may not have used, that would be really useful if you can share those on the chat room, or if you've got any links or anything that you're happy to share.
Sure.
Yeah,
sorry, I just missed the first bit, Angela.
Sorry.
A toolkit for deconditioning, to prevent deconditioning.
Yeah.
Okay. So just on that note, again, this is a question to pose and a discussion point, really. Some organisations that really buy into the appreciating of deconditioning and the harm that this causes would actually go so far as to recognise hospital-acquired infections, hospital-acquired deconditioning as a serious incident. So that we have lots of discussions up and down the country, again, with organisations that are considering that and have considered that, actually, because it's recognising that deconditioning, because of long stay for patients, does cause harm. So that's a discussion point, really. And just another one, actually, is we have this discussion internally, but also externally, is actually, do we need to get to a point where staff, patients, relatives and carers have to consent for admission? Because actually we know that the hospitals are absolutely the right place when you need an acute admission and you're in need of hospital inpatient care. We absolutely know that that's the right place for patients to be. But if you don't need that, and you don't need to be in an acute bed, actually, what do we do then? Do we keep patients in? Do we over-test all of these things happen to patients in our hospitals. And there is, the comms and the communication and the culture is very much that people still have the thought that hospital is the right place to be for everybody for however long. And that's quite difficult on the front line to have those discussions with patients and relatives. So, how do we do that?
Yeah, and I think from a more practical perspective, from my physio background, specifically on the stroke unit, we would have a manual handling chart above each patient's bed that's laminated, dated and signed, so that you can see what the patient's capable of doing, how much assistance they need, whether they need some equipment, and if they can sit out and they can mobilise, what they can do and for how long or how far. I think what we would always encourage patients to do, so if I'm a physio and I see a patient for 45 minutes a day, that's 23 hours and 15 minutes I'm not seeing them. So it's about encouraging the nursing staff, the healthcare assistants, making sure family are trained, relatives that come in to visit, giving everyone the responsibility of getting someone up and getting them moving. So it's not about putting someone in a bed, putting the rails up and saying you're not safe to get out, you're not safe to sit out yourself. It's about putting things in place to minimise the risk, but encouraging people to get up and get moving. Because it's everyone's responsibility. It's not just about a doctor going to the bedside trying to assess something in the bed. It's about, could they get the patient out into the chair? They can get some healthcare assistants, some nursing staff, some therapy staff to help, but it's everyone's responsibility, not just therapists and not just nurses.
No, absolutely, and I think some of the things coming through wholeheartedly agree with that it's not a place of safety. The actual harm is as a result of waiting, and time is the greatest patient currency. That's what we measure patients in. The other thing as well, we've had quite a lot of talk about additional resource to be able to develop or to be able to deliver the reduction in the long length of stay. Some people have asked what resources are there. Is there extra transformation teams or support? So I don't know if anybody has any ideas, or anybody on the chat room, if they can share that. And we've shared and responded ourselves, but it would be really useful if organisations could have those conversations, between themselves and share some examples of practice or how they're doing it or not doing it at the moment.
So we can definitely highlight some organisations that we've personally worked with that have, everyone does it quite differently, don't they? So some people will have additional staff that will just dedicate themselves to either red to green, rolling out red to green. So you have quite a robust red to green team in BHRUT, which is Queen's and King George's in Romford. I know some of the London hospitals will have, they buy into understanding how to improve ward rounds, so they've employed specific people to support that work. There's lots of organisations that will have arms of their improvement team that will focus predominantly on deconditioning, reducing long length of stay, implementing some of the national guidance and some of the tools that we would normally promote, as in the Safe Patient Flow Bundle and Red to Green Day. So there's a variety actually, and then other organisations, divisional teams have the ownership and make it part of their business as usual. So I think there's quite a variety.
So there's been some good discussions and people are beginning to share examples and communicate with each other. So that's really welcoming to see on the chat room. There's been some really good discussions from this.
That's fabulous. Really, really, really welcome that. So we've just moved the slide on and we'll share these with you. And again, once we start collecting and the networking and emailing for all of you that want to continue with the putting people in touch, as it were, we can share our resources most definitely. Is there anything, I'm just wondering if there's anything else anybody wants to specifically ask, or if there's anything that you want that's come through on the chat room, or whether or not we're sort of drawing to a natural close now.
We've had some really positive feedback as well about this meeting approach. People say they really like it, that it's a good approach, that they're getting a lot out of it. So, thumbs up.
Oh, that's really welcome, because actually I think as part of our role, as we see it, as the Emergency Care Improvement Support Team, is very much about trying to acknowledge what's best for you. So what works for you guys is really, we're happy to help and facilitate and provide platforms for you to connect. So this sort of approach, if that works, then that's really good. And as I said, just to reiterate, this is the first session. So I'll just move on to one of our next slides. It's just really...
sorry, can I just ask a question, Helen? Is that all right?
Oh, sure, of course you can.
It's Chris Knight from the UHL. I put something up on the chat room earlier that has been a topic of discussion for us in the last 6 to 9 months, but we're seeing more and more patients actually refusing to leave hospital and wanting to stay in hospital. And as our social care colleagues are finding it more and more difficult to provide effective packages of care, there seems to be a lack of trust from the relatives in that there isn't the availability for the patients they feel to go home safely. So the difficulty we're having is, as much as we're trying to say to patients it's not good for you to stay in here, we're getting a lot of challenge and pushback from the relatives saying, well, it's not particularly safe out there either.
Yeah, that's really tough, isn't it? And actually those conversations are really difficult, aren't they, to have, and a lot of organisations will have different approaches to that. I guess what I would say is that I suppose there's quite a lot of, is there a variety of patients that this is coming from, or is this sort of one, does it tend to be one group, or...
No, it doesn't seem to have any particular pattern. I mean, we are a specialist cardiac and respiratory hospital, so we do have high levels of anxiety patients in relation to their breathing and COPD, and we get a lot of repeat patients readmissions because of its condition related. But the anxiety levels our patients have when you start talking about home are palpable. So when they've come to the end of their IV regime or their infective exacerbations have settled and we talk about going home, you can almost see them going off in front of you with heightened levels of anxiety. And we don't really have, as big as Leicester is, we don't really have an effective resource in the community to respond quickly to those anxiety levels, especially when you know, in the middle of the night, when they wake up early in the morning, when they live on their own and their anxiety takes hold. And that's a really difficult thing for us, because 50% of our respiratory intake is in infective exacerbation and non-infective of COPD?
Yeah.
Well, just so I've done quite a lot of work in London, and although I'm from a physio point of view and from a stroke specialist, we do a lot. We in the trust that I've worked in, we deal with a lot of COPD patients. So we have a very good community team within, and we have a very good pharmacy team within the community. So the patients are provided with rescue packs so that they can self-manage some of their exacerbations before they even get in towards
Yeah, the
ED or the
GPs have
hospital.
stopped giving them out now, so we no longer give out the rescue packs.
Okay, so but I think it's about, if that's an issue for you and it's a significant number of patients, especially those who are 21 days and plus in the kind of cohort of patients that you're seeing, there is something about doing a system-wide kind of collective, what can we do to resolve this? Because being in hospital isn't the best place for patients with COPD. They are able to be at home. There are other resources you can use to keep people at home, but it might be a bigger conversation, so you might have to have your community colleagues or your GP, your primary care colleagues in the same room.
We've just developed a new, I think it's called the RIS team, and they're meant to be going out to see these patients, but because of the resource availability and staff availability, it's a 5 to 10 working day turnaround. Well, I mean, just taking COPD patients as one in particular, as a particular cohort, some of those patients within 5 to 7 days may have readmitted 2 or 3 times. So the preventative side of it is still limited by the availability of access and the resource into those patients quick enough. I know this is early days for this new system, and we're hoping that it will develop over time and they'll be triaging them to get to know their patient. But at the moment, that's the other one is end of life. We seem to be seeing a lot of end of life patients, which then racks up 21-day plus numbers.
Yeah, sure.
That's another big one.
So Chris, that's a really interesting, and absolutely, I'm sure that you're not on your own with that. There is a bit about psychology and whether or not that's that sort of advanced discussion planning, not necessarily as in end of life particularly, but we know with COPD, chronic illnesses, there is a high level of anxiety, and they that sort of support and the emotional side of that and the psychological side of that, the anxiety purposes, really needs to be looked at as well. But this sounds as though if you were to do some kind of, I'm sure you probably already done this, Chris, so forgive me if I'm teaching you to suck eggs, it's not meant in that way, but if you looked at how many patients are readmitted, so your readmissions and how long patients are staying in, and the cost of that versus the cost of additional support in the community, and taking on board workforce and recruitment, then actually you would probably find that the resource would be beneficial to be put into the community to support that, to stop patients coming through, which I'm sure you already know, but that sounds to me as though it's a larger system conversation that needs to be sort of facilitated and helped to get through.
And I think also just using this network, Chris, so if there are people out there who have more advanced kind of community care for respiratory patients, what they've done, how they've managed to kind of take the steps to reduce readmissions. So hopefully if you can connect with any other trusts around the country that are kind of maybe a bit further down the line in dealing with this issue.
Yeah. I mean, it is one of many issues that we've got in relation to lack of community resource, and heart failure is another one. Endocarditis is another one where you just can't go into the community because there isn't the service available. So until they're stable, if they're heart failure and they're offloading and we don't dry the kidneys out, there isn't the facility in the community to monitor the U's and E's on a daily basis. If it's endocarditis and they're on a huge regime of different IV antibiotics, there isn't someone that can deliver 6 IVs a day in the community. We don't do gentamicin and vancomycin in the community, but we do give it for endocarditis. But there's any number of vying kind of departments that require resource availability to facilitate community support. And I think this is the first time that I've heard in a long time where I think the chief exec briefing, having come from the chief exec committee, has said that perhaps now it's time that we need to start investing in more beds, and the bed requirement isn't what it should be, and we should increase it rather than reduce it.
Oh wow. Okay. So I guess that's quite a specific conversation to your organisation. I think.
Well, this came from the National Chief Exec Committee.
Oh, sorry. I thought you were talking about your chief exec.
Yeah. So our chief exec passed that on to us. So whether or not it's now becoming more of a conversation about having more beds available, because over the last X amount of years we've found that the community resource perhaps isn't as effective as we would like to have thought it was going to be. I don't know, but certainly from our point of view, our numbers in this hospital alone have increased from 20,500 admissions through CDU in December 2018 to 27,000 in December just gone. That's 7,000 increase.
Thanks very much, Angela, for the chat room. Those conversations are absolutely fantastic, but I'm just really conscious of time now. So I think this is probably a really good point just to be able to pass back to Helen to have the final.
But Chris, please do put your email address in, and we can connect with you that way, and maybe hope to connect you with other people in a similar situation to yourself, even if it's just for discussions between each other and different organisations. So please do leave us your email.
Yeah, I have done, yeah, and I've worked a lot with Andy and Steve. So yeah.
On the screen now is the next available webinars, and when we're doing so, the next one is we're very much talking about owning your own story and what this means to you guys and how to make a difference with regards to what's going on in your organisation and using your patient experience in your organisations to drive improvement and to drive change. And we are hosting an organisation who's going to come and talk to us about and talk to you about how they've done things and what they've done and what they've seen as a result of that. So we really look forward to sharing the network and the webinar with our colleagues next week. So really welcome everyone's discussions, really happy to be with you and spend this time with you. And thank you so much for spending time with us. We do appreciate the positions that you're all in the acute settings at the moment. So I hope that this has been valuable. I hope that you've enjoyed it, and really do. For those wanting to pass this on, we do repeat this session at 4 o'clock. And for those of you that can join us, please do join us next week on the 23rd, same time, 12:30, for, I talk too much, owning your own story. So I'll say goodbye now. And Callum?
Thank you very much. Lovely talking to you, and keep up the good work.